Welcome, everybody, to our last lecture of the year, an introduction to post-traumatic fatigue. I'm Dr. Richard Davis Batson. I'm the Director of Neurotrauma Education for the Neurotrauma Evidence Synthesis. And we have Rudo Duri here, who's a research trainee who's going to be lecturing today. I'll be lecturing after Rudo, and then we have a exciting panel at the end with 6 different experts from different disciplines, all who have extensive experience working with patients with histories of traumatic brain injury, as well as some of those physicians being traumatic brain injury researchers as well. And we'll probably start the panel somewhere around 7:50, 7:55. And if you need to go for any reason, we're going to be recording this, and this will be posted on our new Neurotrauma Evidence Synthesis YouTube channel. So I want to briefly give an overview of what the Neurotrauma Evidence Synthesis Program is. This is a grant-funded program through the NIH, and we have 2 objectives in the program. The primary objective is to learn evidence synthesis methods. And for those of you that may not be familiar with the term evidence synthesis, it's basically the foundation of evidence-based medicine. And so you'll see in the upper left-hand corner, we have a modified evidence-based medicine hierarchy, and the students and the trainees are learning to conduct sort of gold standard evidence synthesis for the purpose of publication. So that includes systematic reviews, meta-analyses, scoping reviews, and umbrella reviews. Dr. Joshua Goldenberg is the director of the Evidence Synthesis Methods Division. And the goal here is to provide mentorship and collaboration with experienced evidence synthesis experts to then conduct evidence synthesis projects related to traumatic brain injury, and then to publish those results in peer-reviewed medical journals. On the right side, we have the Neurotrauma Education section. I'm the Director of Neurotrauma Education. And what we're doing here is we're teaching the trainees about traumatic brain injury, including the sequelae, the neuroanatomy, pathophysiology, relevant to TBI, TBI diagnostics, and about treatment and rehabilitation, also with mentorship and collaboration. We're asking the students to do projects so they learn to teach, expand, and anchor their knowledge. And then when they become interested in a topic, they can take that into the evidence synthesis group and be part of a publishing process. We're missing a couple slides. So again, the NEST training, or the Neurotrauma Evidence Training, is a grant-funded project through the NIH, and we've discussed the purpose of the NEST training. Disclaimer today, the education here is for educational purposes only. If you have a health problem or medical condition, please consult with a physician or a qualified healthcare provider. The images and content are being presented under fair use for educational purposes. Please don't reproduce this without written permission of the authors. And we have a wonderful companion named Dolly 2024 Artificial Intelligence, who helped to generate some of these images today, and otherwise the images are cited. So I'm going to briefly review the definition of traumatic brain injury, and then Rudo will come on and lecture. As many of you know, a traumatic brain injury is a traumatically induced structural and/or physiologic disruption of brain function due to an external force. And any of the below factors are part of the diagnostic criteria for traumatic brain injury. Traumatic brain injury can occur due to direct impact to the skull, either hitting your head on something or being hit, such as in a sports concussion, for example, through acceleration, deceleration forces in which there's movement of the brain inside the skull, with or without direct impact to the head. And more recently, there's been extensive research on blast injury in the military as a cause of traumatic brain injury. Some of you may be familiar with the schemata from the Veterans Affairs and Department of Defense. This diagnostic criteria for classification of traumatic brain injury mimics many of the other classification systems, whether that be the CDC, the ACRM, guidelines and so forth, as well as the concussion and sports group. So there's a more or less a widespread consensus now on how we diagnose and classify traumatic brain injury. I'm not going to go over this. We've covered this in prior lectures. This is just a review for the neurotrauma students and other attendees. And I will let Rudo take it away to start discussing post-traumatic fatigue.
Thank you, Dr. Batson. As he mentioned, our topic for today is post-traumatic fatigue, and this can also be called post-traumatic brain injury fatigue. And this is basically when there is persistent, debilitating fatigue following a traumatic brain injury. These conditions can be physical, mental, or cognitive fatigue, and specifically focusing on how it's affecting cognitive and physical performance. We can also look at mental and cognitive fatigue, and this is due to impaired neuronal recovery and ongoing neuronal inflammation. And now this is an overwhelming sense of like exhaustion, even after minimal cognitive effort. And so whenever people are suffering from post-traumatic fatigue, there are the areas of the brain which are affected most by TBI. And we look at the frontal lobe, as we know this for executive function and attention, the brainstem for arousal and alertness, and the basal ganglia, which focuses on motor control and energy regulation. Now we're going to talk about the pathophysiology. As you can see, we have the primary brain injury, which is the TBI, and then we're kind of looking down at like the neurometabolic cascade. So as you can see in figure 1, we see that there is the blood-brain barrier compromise. There is also like glutamate excitotoxicity. It can also be pro-inflammatory cytokines. So this neurometabolic cascade, it causes an energy increase in the brain, it impairing the brain's ability to recover fully from activities. And that's kind of what shows up in the post-traumatic fatigue. And now we look at the chronic neuroinflammation. So this is also depicted figure 2. So in this one is looking at how further exacerbates mental fatigue, making it difficult to perform even the simple task. So there can be the mental fatigue, the lack of motivation, and physical fatigue as well. So one of the main pathophysiologies is glutamate dysfunction. As we know, the glutamate is the primary excitatory neurotransmitter in the brain. It is very important for synaptic plasticity, learning, and memory. And it can also be contributing to post-traumatic disruption. We have excessive glutamate release, or it impairs the reuptake in the synapses. It also contributes to neuroexcitotoxicity because there'll be elevated glutamate levels, and that causes damage to the neurons. It also leads to cellular dysfunction, neuroinflammation, and oxidative stress. Glutamate dysfunction also impacts the neuronal networks. It disrupts normal brain connectivity and energy balance, and that can lead to persistent mental fatigue, cognitive deficits, and mood disturbances. So glutamate dysfunction, as it relates to fatigue symptoms, we have that it has a persistent state of neuroinflammation and the disruption of the glutamate regulation. It hampers cognitive resources. It also leads to prolonged mental fatigue and reduced resilience. Some of the therapeutic implications is that we want to do anti-inflammatory interventions. We decrease the neuroinflammation, it can help decrease the glutamate. And then we have the treatments that are directly to reduce the excess glutamate activity as well. And then we have the neuroprotective agents to minimize the damage that is being caused by having an excess of glutamate. So some of the epidemiology concerning chronic post-traumatic fatigue is, as we look at the different phases, in the acute phase, which lasts from like the beginning of the impact, all the way 7 days, 60 to 80% of the patients complain of persistent fatigue. As we continue down to the subacute phase, 1 to 3 weeks, 1 week to 3 months, it can go down to 40 to 60%. It decreases over time. However, that's still pretty high percentages. And as we go chronic phase, it's 30 to 50% are still experiencing ongoing fatigue. If we go down to mild TBI, which is after 12 months, 15 to 30% continue to experience severe fatigue and related cognitive impairments 1 year post-injury. And in the grand scheme of things, the population, 15 to 30% is a very high number who are still experiencing the symptoms. When we break it down to demographics, the research showed that there's significant sex differences in reporting of fatigue symptoms. We saw that women reported more fatigue symptoms than men, but we also found that in research that men underreported fatigue symptoms. So we were wondering, like, this research that we were looking at, as it is showing that the men are underreporting, we're also wondering, like, is it truly that women have more fatigue symptoms, or do we need to get like better reporting from men? And also we look at the age. We found that patients who are older than the age of 60 tend to experience more prolonged fatigue. The recovery is slower compared to younger individuals. When we're looking at the diagnostic criteria, some of the symptoms presentations can be persistent tiredness, low energy, difficult concentrating, mental cloudiness, and the need for prolonged rest after cognitive or physical tasks. We also have self-reporting measures that are used to measure the physical and cognitive fatigue. So these are all a bunch of different tests. So we start with the fatigue severity scale. We have the multi-dimensional fatigue inventory. We have the mental fatigue scale, global fatigue index, the Barrow Neurological Institute fatigue scale, and fatigue and altered cognition scale. All of these are self-reported measures. When we're looking at it for an objective assessment, when it comes to physical exams, there's a very minimal role that is played, but we do like to examine the thyroid because, as we know, most fatigue is impacted by thyroid as well. In a research setting, we do get imaging. We can functional MRIs, PET scans. All of these are meant to help us identify abnormal brain activity and metabolic dysfunction. And the laboratory, we don't have no specific biomarkers for fatigue. However, we do get thyroid function tests to help identify central hypothyroidism, non-thyroidal illness syndrome. And in the research setting, again, we check for the inflammatory cytokines. So when we're looking at the treatment options that are available, we did see that in the research, there was a cognitive behavioral therapy, and this was effective in addressing cognitive, mental, and emotional components of fatigue. And there was a graduated exercise programs. So the goal was to gradually increase physical activity to improve the endurance without exacerbating the fatigue symptoms. We also looked at pharmacotherapy. Of course, with stimulants and antidepressants, they help to improve fatigue and treat comorbid attention deficits and treat comorbid depression as well. All of these treatments show the effectiveness of 40 to 60%, show symptom improvement with tailored intervention. Once again, we saw that there was a difference in sex and treatment responses. Females tend to be more responsive to the treatment. And then it also goes back to like, well, a man also underreporting how well they did because of the baseline was so low when they told us about the fatigue. And this is a systematic review that was done for fatigue after traumatic brain injury for anyone who is interested in learning more about what they found in the research as well. So a lot of this information about post-traumatic fatigue, we also have to look at what are some of the barriers to compliance. And the number one barrier itself is the fatigue. The patients struggle to maintain energy. They're required to follow the structured exercises and cognitive rehab programs, or even go to their doctor visits. We also have some social determinants of health. Of course, we have the socioeconomic factors, the access to the rehabilitation services. If a patient is suffering from fatigue and they're having to travel far and wide in order for them to get their treatment, that can make the fatigue symptoms even worse. Family support and perception. One of the things we looked at is fatigue versus laziness. Depending on the family support system, they could be like, oh, you're just being lazy, versus someone who's suffering from fatigue and they're unable to do the things that are being required of them. So that can also weigh on the patient and become a barrier. We also know that it plays a significant role in compliance and treatment success. So the more barriers that can be eliminated, then the better the patients would do in getting treatment for the fatigue. And so we're now going to look at the prognosis with the best available treatment. When we're looking at mild TBI, recovery is more likely within 6 months. Some individuals, 15 to 30%, may experience ongoing fatigue for a year or more than a year. When it comes to moderate or severe TBI, the recovery is slower. There's a higher likelihood of persistent chronic fatigue. With even the best available treatment, many patients experience partial remission. So this is the 50-30% that we're talking about when they have the residual fatigue impairment. So them not being able to ever go back to their original baseline, which in most people, it might not be problematic, but if you're someone who has a lot of daily activities that require you to perform at 100, and now you're being told that you can't go more than 70%, that is your new baseline. That can greatly impact patients. Then persistent fatigue can be up to 30% of the patients. So the treatment cost can be very expensive. It can reach thousands of dollars per year. And when we're looking at insurance coverages, some of the rehabilitation services may be limited by insurance plans. So insurance can say that, oh, we will cover 8 treatments. However, if the patient falls under the 15 to 30% and they're still suffering from persistent fatigue for more than a year or some out, they might need more appointments, but insurance is limiting them. So that becomes the leading challenge in accessing consistent care for the chronic fatigue. Also, the duration of care may not match the duration of the symptoms. And that's really important when we're looking at all of this.
Okay, Rudo, Duri, thank you so much. Fantastic job. Rudo, again, for those that came in late, is one of our neurotrauma trainees who's learning evidence synthesis. I'm Dr. Richard Davis Batson, and I'm going to start lecturing now. So thank you again, Rudo. We very much appreciate you. Great job. So I'm going to do a brief review and then expand upon some of the primary causes of post-traumatic fatigue. And then we're going to move into secondary causes or contributing factors to post-traumatic fatigue, which is really a multifactorial condition. And then we'll bring in the panelists shortly. I'll probably lecture for 20 to 25 minutes. So in review, Rudo already talked about this idea between the primary brain injury at the time of impact and secondary brain injury. So what secondary brain injury refers to is a cascade of events that can last days, weeks, months, after the initial brain injury. And the most important concept here from a neuroscience perspective is the neurometabolic cascade, which involves an increase in the brain's primary excitatory neurotransmitter, which is glutamate. And this increase in glutamate causes something that we refer to as glutamate excitotoxicity, and we get ion channelopathies or dysregulation between calcium and potassium influx, whereby the calcium moves into the cell, damages the cell metabolically, can lead to further damage and apoptosis of the cells over time, where the cells actually die, which can be one of the causes of progressive brain atrophy, even after mild traumatic brain injury. We also get reductions in cerebral blood flow and glucose uptake, which is an additional component of reduced ability to meet the energy demands, which actually increase after a concussion or brain injury. Neuroinflammation, Rudo already discussed, as well as blood-brain barrier disruption. And more recently, in the last decade, glial cell dysfunction has been an important area of research. Glial cells are supportive cells around the neurons. They're about 3 to 5 times the number of glial cells compared to neurons. And these cells are categorized as astrocytes, oligodendrocytes, and microglia for those that are studying neuroscience. Particularly, the research is focused on astrocytes and microglial cell dysfunction as a key component of secondary brain injury. We also have the dopamine imbalance hypothesis of fatigue, which is that following traumatic brain injury, we move into a dopamine deficient state, so a hypodopaminergic state, which is connected to reduced motivation, attentional deficits, as well as fatigue. And then another emerging area of research that I'm going to cover in the neurosciences are corticostriatal thalamocortical loops, also called circuits. And we're going to talk about those in depth because they underlie much of the pathophysiology of fatigue as well as other conditions. And if you don't want to say that, you can just refer to them as CSTC loops. And you'll find the citations in Table A later on. This is an important work on neurometabolic cascade. Christopher Giza and David Hovda are important neuroscientists. You'll want to review this paper for those that are interested in a more in-depth understanding of the neurometabolic cascade. There is a recent edition of this to make you aware of. So Dr. Giza and Hovda recently published the new neurometabolic cascade. For students that have read the prior paper, there's also an update on the neurometabolic cascade, and you can see some of the topics that are listed here on the right that I will not cover. I would highlight, however, that ion channelopathies are a new area in the neurosciences, moving beyond the well-known ion channelopathy in the neurometabolic cascade. This has been extended to include other channels as well. This is a schemata of everything that can happen in secondary brain injury. I will not cover this. The point here is to understand that we have many things happening downstream from the initial concussion or brain injury event that can lead to ongoing disease processes as a result of the injury. Dr. Brent Masel will be with us later today. This was a landmark paper that he published along with Dr. DeWitt in 2010. I highly recommend you read it. It really reframes traumatic brain injury as a disease process and not an event. And so we need to be thinking about this more like a neurodegenerative disease, as something that may be ongoing as opposed to a singular discrete event that occurred in time. So with respect to these corticostriatal thalamocortical loops, I've put a couple of these loops here. There are more loops than these, but these are basically an interaction between the cortex, and here you'll see both the dorsolateral prefrontal cortex as well as the ventromedial prefrontal cortex, and the connection with an area of the basal ganglia referred to as the striatum. Thalamo refers to thalamus, and again, cortical back into looping into the cortex. Here's another schemata of some of the CSTC loops. The corpus striatum you can see on the right, which includes the caudate nucleus and the lenticular nucleus. For those in the neuroscience program, recall that the lenticular nucleus of the basal ganglia is the putamen, as well as the globus pallidus. So the striatum plays a central role in fatigue and in a number of neurological and psychiatric conditions. This is an imaging model on fMRI of the CSTC loops, and you can see how the CST loop response changes with different types of tasks. And so this is sort of the new wave of neuropsychology, if you will, is to start assessing patients inside of fMRI scanners with various tests. You can see that there's a go, no-go task here, which is a classical test that's used in neuropsychology, now being used in an fMRI paradigm. And in this way, we can compare responses in the CSTC loops with healthy controls across a number of disease conditions. Probably the most well-researched condition in CSTC loops is actually obsessive compulsive disorder. These are citations regarding neuroimaging studies using PET scans. So the FDG stands for fluorodeoxyglucose positron emission scan. And we also have fMRI scans here. And what's interesting about this is you can see, number one, there's clear disruption even in mild TBI. That's one take-home point. And the second is that there's an extensive amount of research in the fMRI setting on dysfunction in the CSTC loops in brain injury, specifically connected to fatigue. And you'll have access to these slides later on for those that want to review that. So the CSTC loops are critical because they underlie many of our psychiatric disorders. They underlie movement disorders in the neurology field and Parkinson's disease, Huntington's disease, as well as Tourette's. And then everything from schizophrenia, major depressive disorder, anxiety disorders, OCD, substance use disorders, eating disorders, attention deficit hyperactivity disorder, or ADHD. And most importantly, I've highlighted here that research has shown involvement of the CSTC loops in post-traumatic stress disorder, chronic pain, and in traumatic brain injury. And in our program, we talk about the intersection of post-traumatic stress disorder, chronic pain, and traumatic brain injury as amplifying factors. In fact, this is referred to as the polytrauma clinical triad, which has been in military research and more recently in the motor vehicle collision research environment. So we're now going to move into secondary causes of post-traumatic fatigue, and we're going to be covering briefly each one of these topics. As you can see, there are many factors that can contribute to or perpetuate post-traumatic fatigue, and we're going to move through each one of these, and then we're going to have a panel discussion with different experts from each one of these disciplines a little bit later today. So chronic pain itself is well known to contribute to fatigue. And there is a direct and linear correlation between musculoskeletal pain intensity and fatigue severity. There's a temporal relationship, and what that means is changes in pain precede changes in fatigue. So if your pain goes up, your fatigue follows. If your pain is mitigated and goes down, your fatigue goes down. We're going to have some pain physicians later today, Dr. Virtaj, Singh, and Dr. Richard Seroussi. I consider pain to be probably the starting point when I'm dealing with post-traumatic fatigue. The first question I ask is, how's your sleep? They say it's bad. I ask them why. They say pain wakes me up. And until you mitigate the pain, you're going to continue to have sleep disruption. So you can see there's a number of mechanisms. However, the mechanism behind chronic pain contributing to fatigue is not simply sleep disruption. So within the research community, we've looked at systematic inflammation as a cause of fatigue. Particularly, you'll see elevated interleukins, changes in heat shock proteins, actual reductions in brain-derived neurotrophic factor. We previously discussed the role of CSTC loops, reduction in dopamine levels, and structural and functional changes in the corticolimbic structures, which are part of this CSTC loops. This is a very good paper by Yang and Chang on chronic pain, and this is a structural and functional neuroimaging review. And you can see on the right here all of the areas that are affected within the corticolimbic structures related to chronic pain. And so really the take home in chronic pain is it's very much like a secondary brain injury. So chronic pain over time causes structural and functional changes to the brain. And if it's not mitigated, it is amplifying the effect of the traumatic brain injury. So we want to really start to think about chronic pain when there's polytrauma, whiplash, post-traumatic headaches as a secondary type of brain injury that's ongoing. And this is true of PTSD as well. We'll talk about that as we move through that section. We have Dr. Gandis Mazeika here today, who will be with us. He is a sleep physician trained in psychiatry and neurology. Sleep disorders are fundamental to understanding post-traumatic fatigue. And so in my practice, and I've put these in order for a reason, which is I'm thinking about chronic pain and sleep at the forefront with ongoing fatigue complaints. And this is a list of all the different sleep problems or disorders that have been reported secondary to traumatic brain injury. Also have insomnia due to post-traumatic stress disorder as well. And Dr. Gandis Mazeika will be lecturing next year on post-traumatic sleep disorders. So I'm not going to cover a lot here. Just be aware that sleep medicine as a discipline is a critical part of a multidisciplinary team that's assisting in the rehabilitation process for those with traumatic brain injury. I do want to mention the comorbidity of depression and insomnia with traumatic brain injury. This is an important paper by Tomar and colleagues, and you'll note that the comorbidity is very, very high between these three conditions. And the directionality in this study is not necessarily known. We know that sleep deficits amplify things like headaches. Sleep deficits amplify symptoms of depression. Depression makes sleep worse. Traumatic brain injury makes sleep worse. Traumatic brain injury can cause depression in and of itself. But these three conditions work in tandem and have to be addressed clinically in tandem. This is an interesting evolution in neurosciences. For those of you that have not read about the glymphatic pathway, the glymphatic pathway is a newly described network within the brain whereby perivascular spaces are supporting the clearance of solutes that are between the cells, essentially, getting rid of wastes in the brain, primarily during sleep. And there's now an emerging body of literature that suggests disturbance of the glymphatic pathways after traumatic brain injury, including concussive brain injury. And this particular paper is on impaired glymphatic pathways leading to post-traumatic headaches. So you can see the conundrum here. We've got bidirectional relationships. So a TBI impairs the glymphatic clearance of solutes in the brain, disrupts sleep in and of itself, and perpetuates post-traumatic headaches, which then contribute to insomnia. And so we have the need for a multidiscipline approach here, again, understanding these amplifying pathways. Post-traumatic depression is well recognized. within the research community, secondary to traumatic brain injury. As we all know, fatigue is one of the most common side effects of depression, and depression itself is multifactorial. You'll have to look at all of these different factors that can potentially contribute to ongoing depression that are listed here. In terms of biochemical changes, depression is not limited to a psychological disorder. The neurosciences have moved way past a Cartesian model of mind-body split or dichotomy to understand that conditions like depression have a neurobiological basis. There are biochemical changes as well as structural changes underlying depression, even independent of traumatic brain injury. The classic structural damage model has historically been in the dorsolateral prefrontal cortex area, and this is also a target area for treatment with transcranial magnetic stimulation. You will also see that some of the similar problems inside of the depression model that we see in the neurometabolic cascade, so persistent elevations in inflammatory cytokines, as well as glial cell dysfunction. Post-traumatic stress disorder, as many of you know, you're working with PTSD with many of your patients. If you're in the brain injury environment, this is quite prevalent in the motor vehicle collision setting. The last paper that I reviewed from 2018, PTSD was 22% in males and 28% in females following motor vehicle collisions. So about 1 in 3 females are going to go on to experience post-traumatic stress disorder following a motor vehicle collision. And PTSD is associated with both mental and physical fatigue. It reduces the time to physical fatigue specifically, and those with a history of PTSD are 8 times more likely to report chronic fatigue. And again, coming back to the disruption in CSTC loops, also demonstrated in PTSD as well. So a common substrate, again, that underlies pain, PTSD, and traumatic brain injury, the CSTC loops. Post-traumatic stress disorder is now viewed as a biological disorder. Again, we've moved past the Cartesian model of mind versus body, and post-traumatic stress disorder being a psychological condition. This is a very, very important paper that came out in 2012 by Pittman and colleagues at Harvard. And the researchers, probably the most comprehensive paper to date on the neurobiology of post-traumatic stress disorder. And you can see on the right here some of their findings. We can see hippocampal atrophy, shrinking of the hippocampus in post-traumatic stress disorder. That hippocampal atrophy obviously underlies things like Alzheimer's disease, can also occur in traumatic brain injury. And as many of you know, the hippocampus is central for encoding new memories and also retrieving memories. So putting something in, taking something out. Also structural changes in the prefrontal cortex. Functional imaging has revealed changes in the amygdala, ventromedial prefrontal cortex. That should say DAAC, that's the dorsal anterior cingulate cortex, hippocampus, and insular cortex. And receptor imaging has also showed changes with the GABA receptor and serotonin receptor systems. Again, changes in neurocircuitry that are affecting the amygdala. And then from the neuroendocrine perspective, catecholamines and disruption of the HPA axis. More recently, we've looked at allopregnanolone and pregnenolone. These are very important neuropeptides that particularly help with promoting sleep and reducing anxiety, and disruption in these pregnenolone and allopregnanolone neurochemical pathways can aggravate or contribute to the development of anxiety and insomnia. And then other classical neurochemical alterations, glutamate in particular. PTSD itself can lead to an excess glutamate state. And so when we've talked about the glutamate hypothesis of traumatic brain injury, you can get an excess glutamate milieu in both TBI and PTSD independently. meaning it can occur in PTSD independent of TBI. And when they co-occur together, it can amplify those effects. Autonomic dysfunction. We're moving away from some of the psychiatry now. Autonomic dysfunction is a well-known cause of fatigue. Dysautonomias are an important part of our brain injury medicine. The central autonomic networks that are implicated here are listed. And this is basically referring to the autonomic nervous system. So this is the balance between the fight or flight sympathetic nervous system and what we call rest and digest or parasympathetic nervous system. And dysautonomias can go in either direction. And so we can get sympathetic dominant dysautonomias as well as parasympathetic dominant dysautonomias. However, sympathetic dominant dysautonomias are more common, meaning you'll see elevated heart rate, elevated blood pressure, and other classical symptoms that are associated with increased sympathetic overtone or fight or flight response. Dr. Gianoli is here today, and as our neuro-otologist, he recently lectured and talked about the vestibular autonomic reflex, which is one of the 4 reflexes within the vestibular system. And when this particular reflex is impaired, it can also be a secondary cause of dysautonomia. Again, here's some of the pathways that are involved in dysautonomias, and I won't go over all these pathways. Those of you that are in the neuroscience studies will want to review these and know this content. I would highlight here that even in mild TBI, we can see autonomic dysregulation. So Estrov's study showed abnormalities in all of these 4 features, so heart rate variability, pupillary dynamics, eye pressure, and arterial pulse wave. More severe traumatic brain injury can lead to cardiovascular and renal dysfunction as well. Dr. Gianoli was here again lecturing on vestibular disorders in October and early November. He did mention at the time that vestibular disorders are associated with fatigue and covered some of this. However, I'm going to reiterate and expand upon some of these points. So daytime fatigue is associated with more severe vestibular symptoms, and there is an emerging body of literature, and you'll note some of the dates on here, starting in 2018, about sleep and vestibular dysfunction. And so vestibular disorders are now recognized to induce sleep disturbances. And again, there's a bidirectional relationship. Sleep deprivation and sleep apnea can actually affect vestibular-related ocular motor function. So how the eyes move, mitigated through the vestibular system, as well as postural control. Vestibular disorders are associated with impaired sleep quality, and they're also associated with either sleeping too much or sleeping too little, as well as a higher percentage of REM sleep and more severe anxiety being associated with vestibular symptoms. There are projections from the medial vestibular nuclei in the brain system to the lateral hypothalamus orexin hypocretin system. And when Dr. Mazeika lectures, hopefully he will talk a little bit more about the orexin hypocretin system. But for those of you that are not familiar with the orexin hypocretin system, these are primary neurotransmitters involved with arousal. And so when there are deficits in orexin hypocretin, you get a decreased arousal, excessive daytime sleepiness, and it can also underlie a condition referred to as post-traumatic narcolepsy. And so we now know that the vestibular system actually talks to the orexin hypocretin system, and thus the need for sleep medicine physicians to talk with neuro-otologists. And we're going to have an interesting panel today. Dr. Gianoli will get a chance to meet Dr. Mazeika, and we'll talk more about those connections. Unilateral vestibular lesions have also been shown to activate the HPA axis, the hypothalamic pituitary axis. This may also be another mitigating factor related to fatigue. And there's some emerging data that these same CSTC loops may underlie vestibular disorders. So there is a vestibular striatal pathway, which means The vestibular system also talks to the striatum of the basal ganglia, which is involved in that CSTC loop. But that, again, is emerging, and we don't have enough data yet on that, just an area of further exploration. This is just an example of the crosstalk between the vestibular system and the hypothalamus. So the medial vestibular nucleus has projections to the autonomic nuclei of the hypothalamus. So that's one of the pathways through which we can get secondary autonomic dysfunction due to a vestibular disorder. And also, again, in review to the orexin hypocretin systems, which are involved in fatigue and arousal. Neuroendocrine dysfunction. Dr. Randall Urban will be here later on today. He's an endocrinologist. This is my primary area of research. Post-traumatic hypopituitarism is a set of conditions that can occur after traumatic brain injury. This will be a separate lecture. This has historically been thought to be due to disruption to hypothalamic and/or pituitary function. And this is a list of different variants of post-traumatic hypopituitarism. So the first one is central adrenal insufficiency, which is actually a potentially life-threatening condition that can occur following traumatic brain injury. And it disrupts the hypothalamic pituitary axis by the individual's not able to mount an appropriate cortisol response to a major stressor, such as an accident, a hemorrhage, a severe illness, and they can die due to something called an adrenal crisis. A common symptom of central adrenal insufficiency is fatigue. Central hypothyroidism is due to dysregulation of the signaling hormones from the hypothalamus and/or pituitary, as opposed to primary hypothyroidism, which is most of what America has in autoimmune thyroiditis or Hashimoto's. So this is due to impaired TSH signaling to the thyroid, and so you get a thyroid dysfunction of central origin rather than from the gland itself. And this is something that in endocrinology we have to screen for when we're evaluating a patient for neuroendocrine dysfunction. And as we all know, fatigue is a classic symptom of hypothyroidism, whether it be primary or secondary. Another variant of hypopituitarism are sex steroid deficiencies, hypogonadotrophic hypogonadism. That occurs in males via decrement in testosterone and in females in estradiol and progesterone. And again, loss of estrogen, loss of testosterone associated with fatigue. Growth hormone deficiency, which I'm going to talk about subsequently, is the most common variant. This is adult onset growth hormone deficiency as opposed to childhood onset growth hormone deficiency, as well as arginine vasopressin deficiency, which is formally referred to as central diabetes insipidus, which is due to a deficit of the neurotransmitter antidiuretic hormone from the posterior pituitary. And then I will briefly mention a neuroendocrine condition referred to as brain injury-associated fatigue and altered cognition, which has been the focus of our research group at University of Texas Medical Branch. We'll cover that very briefly today, and then Dr. Urban will be with us later today to discuss that with the other experts. So growth hormone deficiency is very common following traumatic brain injury. This is now widely accepted within the field of endocrinology. This is research from our group at the University of Texas Medical Branch that we presented at the Endocrine Society this year. This is a combined cohort from my clinic and University of Texas Medical Branch. And we found that 18% of individuals who have persistent post-concussion symptoms at greater than 12 months with uncomplicated mild TBI have growth hormone deficiency. And this is higher than prior studies. And again, this is a selected population, but it's the type of population that we often see in our practice. So roughly 1 in 5 individuals that have ongoing post-concussion symptoms who have had a uncomplicated mild TBI may go on to actually develop classical growth hormone deficiency. These are papers from the University of Texas Medical Branch. outlining a new condition that we refer to as brain injury-associated fatigue and altered cognition. And these are growth hormone abnormalities that fall outside the classical diagnostic criteria for growth hormone deficiency. However, this group of individuals has been well identified at this point and treated in an initial clinical trial with great benefit, including changes in brain structure, cortical thickness, gray matter, and functional connectivity. And again, we have Dr. Wright here today as well. Kate Randolph is here today, Brent, Masel, and there may be some others from the University of Texas Medical Branch. But a very important treatment intervention is growth hormone in these particular individuals. This is a brief review of perhaps why growth hormone works so well in both the growth hormone deficient or growth abnormal patient. These are all of the brain regions that contain growth hormone and or IGF-1 receptors. IGF-1, insulin-like growth factor, is a downstream hormone, sister hormone, if you will, of growth hormone. So you can see that the brain is innervated with important receptor sites throughout multiple networks. Additionally, growth hormone and IGF have neuroprotective effects for the brain and may actually help with repair of the brain. And this is what our initial research suggests, that there may be an actual reparative effect from the growth hormone. Medications you have to always consider inside of the post-traumatic fatigue space. So we're always checking for medications that can contribute to fatigues. To fatigue. That will include your analgesics, your muscle relaxants, your triptan medications, your antidepressants, particularly SSRIs, anticonvulsants that are used in pain management like gabapentin and pregabalin, as well as other sleep medications. So as you're moving through solving the riddle of post-traumatic fatigue, just make sure that you're looking at potentially altering or changing medications if the fatigue is debilitating. Finally, we have reduction in activity, exercise, and deconditioning as an independent cause of fatigue. And again, one of the primary reasons for this is ongoing chronic pain, restricted range of motion. Additionally, the motivational aspects. So the depression, the impaired dopamine networks, neuroendocrine dysfunction, sleep disturbance, make it real difficult for people to exercise, and they just stop exercising over time. And with the deconditioning, you actually get a change in mitochondrial function over time. And this can be an independent factor that contributes to the fatigue. And again, there may be medications that are keeping them from exercising. And so you may need to change the medications to be able to provide a little bit more motivation. And even though stimulants are not necessarily a great long-term solution, they are for some individuals. Stimulants can get people back up and moving once they've sort of mitigated the pain picture and the restricted range of motion. And they may get on stimulants to be able to start a routine or an exercise routine, and at some point get off of those stimulants as well. And then, of course, fatigue itself is a vicious cycle, and essentially fatigue keeps people from exercising and so forth, leading to deconditioning. So in review today, we addressed primary causes of fatigue as well as secondary causes of fatigue. We are now at 8 o'clock, and that was my target time to bring on the panel. And so we're going to now move into our panel experts. So if the panelists could please turn on their cameras. Yeah, thank you, doctors, for coming today. We really appreciate you guys showing up. We're just going to kind of do this freestyle and talk about post-traumatic fatigue. And we presented a lot of research already, so I think the focus here would be to talk about the clinical aspects. You physicians have been involved with brain injury medicine for many, many years. I'd like to do a full biography for all of you. I think that would probably take 15 minutes to get through the biography. So with all due respect to all of you, I'd like to just bypass some of that and just talk about what you do clinically. Dr. Masel is a board-certified neurologist at University of Texas Medical Branch. He's one of our oldest brain injury neurologists in the country. He's contributed immensely to the field of brain injury medicine, and he is one of the I said yesterday in our meeting, he was one of the fathers of post-traumatic hypopituitarism, along with Dr. Urban, and he said he didn't want to be a father, he wanted to be an uncle. So he's now one of the uncles, I guess. And Dr. Urban is a endocrinologist at the University of Texas Medical Branch. Accolades to Dr. Urban. Again, he pretty much started the field of post-traumatic hypopituitarism, which has been my area of research. And he has taken it outside of the traditional endocrinology box to be able to treat a much broader group of patients with ongoing fatigue and altered cognition within the BIAFAC paradigm that we've discussed. Dr. Mazeika is a board-certified sleep medicine physician who comes from psychiatry and neurology background. He did fellowships in all three. He's been an indispensable resource over the years in the Seattle area in rehabilitating individuals with sleep disorders after traumatic brain injury. And Richard Seroussi, Dr. Seroussi is a physical medicine rehab physician who is in the trenches every day with extensive experience, not only dealing with traumatic brain injury, but all of the other polytrauma that occurs with traumatic brain injury. And it should, so welcome, gentlemen.
Thank you.
Thank you. Good to be here.
I'd like to start with Dr. Masel. And many years ago, you published this paper that we cited today about concussion as a disease process and not an event. And can you talk with us about that, particularly as it relates to post-traumatic fatigue?
Well, thank you. And first of all, I want to say it was a great. The first hour was just was great. I really learned a lot. I think it was you did a wonderful job. My story is I'm on the board of the Brain Injury Association of America, and flying up to a meeting in Washington, and it just sort of dawned on me. I mean, truly, the light bulb went on, and I thought, we're doing this all wrong. We're throwing enormous resources at people acutely after the brain injury, but we know that people with brain injury survive, and they go on to have lots and lots of problems that you scratch your head and say, well, how in the world is this related to the brain injury? And so during a break in the meeting, I said, I have this idea on the airplane. And the executive director said, well, you need to write a white paper, because at the time the Affordable Care Act was bubbling through Congress, and they wanted to get brain injury as one of the covered conditions. And so I wrote a white paper. But as you all know, you get no street cred in academic medicine unless it's in a peer-reviewed journal. So I got with Doug DeWitt, who's a basic science guy at UTMB, and we started on the paper, but we got hit by a Hurricane Ike. And so I was able to do the dog ate my homework kind of excuse for not getting this done. And then I was told, well, you're going to be presenting this in January, so you better get it done. So that was the beginning of it. And it, and a lot of people have commented on this, and quite frankly, it was just like writing a term paper. I mean, it's not like I discovered the cure for cancer or I came up with some great research concept. The evidence was all there. It was just a matter of putting it together. And what we now recognize is that there are lots and lots of issues that patients develop later on that aren't necessarily logically would say, well, how in the world is this related to a brain injury? Why did they develop skin disease? Why do they develop all these GI problems? Why do they develop bone problems? Why do they develop urologic problems? And it's, the knee bone's connected to the thigh bone, and the brain pretty much runs the show. And we are now clearly into a different phase where we are recognizing this. and approaching brain injury in a different way. We were looking beyond that first golden 90 minutes or so after the traumatic brain injury, when there's this whole cascade of events, and looking at a lot of the issues that occur later on and trying to answer that. And I would stress, I'm still involved with the Brain Injury Association, and we've been talking about the concept of the cure, but it's really not the cure. It's really not finding the cure, singular, is finding the cures. And I would encourage people on this call, as they think through all that has been presented, these are just pieces of the puzzle. There's none of these, I don't think, that's going to be the eureka moment that's going to get somebody the Nobel Prize. They're pieces of the puzzle, and then we will put all these pieces together, and maybe we can make some differences. And that's quite frankly why I was so excited hooking up with Randy Urban and the rest of the group many years ago, because most of what we do this was 30 years ago, was treat symptoms, and it's like, if you have a heart attack, okay, we'll give you some morphine and then your symptoms will get better. Of course, you got to do something for the underlying problem. And the neat thing about what's happening now and the stuff that you presented, Davis, and like I said, the stuff that we're doing here in Galveston, is that we're treating the underlying problem, because that really makes people better, not just the symptoms, but it really makes them better. So that's my take on this. And I'll pass the baton.
Well, let me give you a rubber hits the road question. Historically, what did you do? What was your go-to for post-traumatic fatigue? How has that changed over the years, and what do you do now?
The go-to is antidepressants, which frequently made them worse, quite frankly, and then stimulants. And in those days, we were very cautious about stimulus and concerns about it causing somebody to have seizures, especially, a large percentage of people with TBIs have seizures. Although we've come to realize it really doesn't make that much difference. So we would treat them with stimulants, and then a lot of it is the sort of like cognitive behavioral therapy. I mean, one of the hardest things as a practicing physician is getting people to exercise. It is banging my head against the wall. I came home one day and I said to my wife, I negotiate exercise with patients. It's too hot. I can't go out. We'll go out in the morning. Well, the mosquitoes are bad. Well, then spray, on and on. But a lot of it is that push to exercise, because I think that makes an enormous difference, but it's hard. It is really hard to get people to exercise. So those were my approaches.
Fantastic. Let's this is a spontaneous order. I think we have so many amazing gentlemen here today. I think let's go to Dr. Mazeika. And this is a fundamental discipline. So he's a sleep medicine physician. So Dr. Mazeika, you and I have known each other for a long time. Somebody shows up at your clinic. You're a Jedi here. You've got lots of tools in your toolkits. Their chief complaint is, I had a TBI and I'm exhausted mentally and physically. What do you do? How do you approach it?
Sure. Well, gosh, everyone's going to be a little bit different, right? You have to take so many things into account. How far back did the TBI happen? How severe was it? How was it graded? What was the Glasgow coma score at the time of the accident? What did the immediate post-recovery kind of trajectory look like? Are they stuck, or are they continuing to improve? The last thing you want to do is kind of get in the way of kind of spontaneous improvement, right? You want to do it as little as possible if they're still on the mend spontaneously. But since we are sleep specialists, we do tend to see things through a certain lens, and that's the contribution that we can provide to the overall kind of team process. So once we've gotten a sense of where they are in their trajectory, obviously we're going to be asking the usual kinds of medical questions, just to be sure that they don't have confounding medical issues, whether it's polypharmacy, whether it's pre-existing conditions, whether it's stuff that's already happened consequent to the brain injury, such as hormonal disturbance and so forth, or obviously chronic pain, which is probably first and foremost. So many of the patients who come to see us have daily headaches, right? And that can, those can extend into the sleep period. They can arise in the middle of the sleep period. So we're always focusing on the nature of the headaches. Are they tension type? Are they migrainous? Do they have symptoms that are could potentially impact their related systems such as digestive function and so forth. The reason why that's relevant for us is because if we choose to medicate the patients, if they're having migrainous type of pain and their intestinal transit time is slower, then we need to medicate them earlier in the evening to be sure that the medications are actually taking effect at the proper time. These are just throwing some random stuff out. But that being said, we find sleep disturbances in so many individuals that we are compelled to study them. And so we're always focusing on not just the breathing in their sleep. Of course, many people who, in the U.S., regardless of whether they have traumatic brain injury or not, have sleep breathing disturbances, right? It's just endemic. But the number is, I think, enriched among people who've had, a brain injury for multiple reasons. So we want to be sure that we identify that and kind of get the sense of the nature of the breathing disturbance. But we like to go beyond that and we'd like to see what other kinds of smoking guns we might find. It's not unusual for individuals who've had traumatic brain injury to have a shift in their circadian pattern. They often develop a delay in their circadian timing. I have no idea how that works, but it's a thing. Not everybody gets it, but we look for it, and it's very important to identify that because those individuals will be complaining that they're just wiped out every morning, like they didn't sleep at all. When actually it could simply be that that their brain is still wanting them to be asleep, but they're waking up because that's when they think they're supposed to wake up, or if they're still working, that's when they have to go to work, for instance. So we like to identify those kinds of things. Many individuals, are tired throughout the day, and one of the things that's very difficult for us to tease out, it's a constant challenge, is where does the fatigue end and where does the sleepiness begin? There's the overlap very tightly. So people who complain of fatigue may simply be sleep deprived. Not everybody who is, chronically sleep deprived will manifest symptoms of sleepiness. Some are tired and wired, so to speak. They have a kind of a hyper, autonomic state that's possibly just kind of reactive to to their circumstances. They don't necessarily perceive themselves as sleepy. And they may not even perform, like on a multiple sleep latency test, a daytime sleep test, to assess the degree of sleepiness. Some of them are just too jacked up to be able to, to perform naturally and to show us their underlying degree of sleepiness. So it can be, difficult. So I'm sorry, I'm rambling on, but those are some of the considerations that kind of come to mind when we assess these individuals.
Fantastic. Yeah. So I think, you're referring for the audience, this intersection between fatigue and excessive daytime sleepiness, which we call hypersomnia. You've done a lot of research on post-traumatic narcolepsy. And can you tell us where that fit? What is it? Where does that fit in? How is that different from just hypersomnia or excessive daytime sleepiness?
Yeah. Well, it's known. So for the students, there is, Davis did talk about the hypocretin system, and it's a great story. It's really worthy of a read. It's a fairly recently discovered, neurotransmitter system that's really key to the management of alertness and vigilance in the brain, and the hypocretin containing neurons the cell bodies are located in one of the lateral nuclei of the hypothalamus, and When a person gets a hard enough shake, those cells can be stunned. And so hypocretin secretion generally drops dramatically post-injury in the first month or two. So this very nice series that was published in Switzerland around 2010 or 2012 by Christian Baumann showed, I think they took 65 people who were, consecutive people who were admitted to, University of Zurich for, moderate TBI, and their hypocretin just, CSF hypocretin just bottomed out. And in the vast majority of them, within 6 months, it had rebounded to normal. So the cells were stunned and then they come back. But a certain percentage of them did not. And so the question there was, was there enough damage done to these cells, bodies or the supporting, kind of glial network surrounding them that they were no longer able to, be viable. And so when that happens, that is essentially one form of narcolepsy, because narcolepsy, the classic form of narcolepsy, arises because of a deficiency of hypocretin neurons. In the classic model of narcolepsy, it's an autoimmune problem. It's a kind of an innocent bystander attack, targeted by T-cell response. But in the post-traumatic narcolepsy is really more of a traumatic, kind of cascade of events that leads to the dropout of hypocretin neurons. It's thought that not everybody with post-traumatic narcolepsy has that issue. Some people also have disruption in the hypocretin circuits, because hypocretin does project fairly widely to the cortex and also down to the brainstem. And some of those circuits may be disrupted, which can lead to very similar symptoms, although the cells are still, bodies are intact, but the connections are no longer intact. So those are the two main features, but the symptoms are still the same, which is people with narcolepsy in general have an instability of sleep and wake states, and in particular REM and non-REM states, where sleep will verge into wakefulness, wakefulness verges into sleep, almost kind of randomly, but not quite randomly. There are triggers, right? That also REM states converge into sleeping, wakefulness, such that people will have, lapse into kind of a dreamlike state, and they can have hypnagogic hallucinations, very much like a true hallucination. They think that somebody has just walked in the room. They hear a voice. They really can't distinguish between, reality and what, in their state. And so it's quite, it's hallucinatory. And all those things happen in every flavor of post-traumatic narcolepsy. It's a peculiar thing. It's turns out to be pretty common post-traumatically. We have a skewed series, but roughly, I took a look at 40 or 30, maybe 37 consecutive patients that we looked at, and about a quarter of them met the criteria for post-traumatic narcolepsy. These were people who had moderate traumatic brain injury. I certainly don't think that would be a number that would be representative of the broader population, but obviously they were referred to us because they had sleep problems. And so once you kind of pass that hurdle, then the prevalence of narcolepsy is extraordinarily high. Mind you, the prevalence of narcolepsy in the general population is about 1 in 1,000, maybe 1 in 2,000. So to have a quarter of these, individuals meeting the criteria for narcolepsy is extraordinary.
Yeah. So I have another question for you, but I want to highlight something that Dr. Mazeika said. Because this is an epidemiology program, I want the students to start thinking about, when you read prevalence data, are we talking about a global population, or are we talking about a select population? Because as a clinician, you're going to get select populations. The people that recover from TBI, you're never going to see. So what Dr. Mazeika is referring about is the people that end up in his clinic, or the people that end up in my endocrinology practice, or Dr. Urban, are select, which means that the prevalence is going to be much higher. And so we talk about sort of pretest probability. And so you don't want to just read, when you read a study, you don't want to calculate your pretest probability from a global population. You want the population to most closely match who you're going to see in clinic. which for like Dr. Mazeika and myself, it's often chronic phase after TBI. They've seen multiple providers. They're not getting better. So that's going to be what you want to factor into your pretest probability. So just wanted to mention that. And I really want to go to our next doctor, but I have to ask you one more question, Dr. Mazeika. You made me aware some years ago, we were sitting on a patio somewhere, and you made me aware of the glymphatic pathway. And I said, what? The glymphatic pathway? And I don't know how many people have heard of the glymphatic pathway, but my first question is, can you tell us what that is? Reiterate it, because I covered it. And were you aware about this amplifying effect of lack of glymphatic clearance perpetuating post-traumatic headaches, and then of course the headaches disrupting sleep? So pass it over to you for that.
Well, I'm going to profess some ignorance about the connection between lymphatic clearance or lack thereof and headaches. I can see the intuitive connection, especially if there are compounds that are neurotoxic or potentially neuroinflammatory that are not being cleared at an adequate rate, so that there's you develop a concentration of those products. As to whether the lack of adequate lymphatic clearance can boost CSF pressure is a really interesting question, because a lot of people with post-traumatic headaches do complain of headaches in the morning that then abate a little bit as the day progresses, which to me has always been a red flag for for a CSF equilibrium type of process. But yeah, it's basically extracellular clearance through kind of pathways that are essentially mediated in kind of in between the astrocytes that then end up collecting in the central venous circulation, right, and then end up being drained into the venous pathways, right? So it's a little bit kind of outside the classic lymphatic pathway, right? It doesn't go into the into the usual collection mechanisms, right? But anyway,
so in essence, clearing brain debris, and my understanding is that this happens in greater magnitude during sleep. And so how does sleep architecture affect lymphatic clearance of these debris and toxins?
Well, it's these pathways open up primarily during non-REM sleep, and at least in mouse models, they appear to be most open and most efficient at clearing during N3, which is the deepest stage of sleep. Haven't seen that that's been confirmed in humans yet, but I think that would be a kind of a plausible hypothesis, that probably N3 sleep is where most of the kind of lymphatic clearance of toxic materials, amyloid, and related products happen during sleep. And from some preliminary smaller scale trials, it appears that position has something to do with it as well. Clearance seems to be better when you're on your side as opposed to when you're supine. And so, if there is one little pearl that I could kind of share, that would be for individuals who do have post-traumatic headaches, encouraging side sleep may potentially be of modest benefit for them. So, using positioning pillows or some other strategy to help them sleep on their side.
Okay, fantastic. So it's really hard. What I'm trying to do today is just literally play off of a concept. So there's two things that you mentioned, which one is potential increase in ICP, intracranial pressure, secondary to lack of lymphatic clearance. And then you mentioned N3 sleep. And so we know as endocrinologist practitioners that N3 sleep, the largest pulse of growth hormone happens in N3 sleep. And when we get growth hormone aberrations, it compromises N3 sleep. So this raises the question regarding the interrelationship between growth hormone deficiency, sleep, N3 sleep, and lymphatic clearance. And I want to bring Randy in to talk about this. And then I've got Dr. Gianoli, who previously talked about increases in intracranial pressure as a target for treating vestibular disorder. So I feel like I literally need to flip a coin. Maybe I'll go with, maybe I'll go with Dr. Urban now and have you come in, and then we'll move to Dr. Seroussi and Dr. Gianoli. Dr. Urban, your area of research, as everyone knows, is post-traumatic hypopituitarism. Can you tell us a little bit about how you got involved with that research and how it's evolved over the years? And then obviously anchoring that concept to your recent research on fatigue and altered cognition.
Sure. Thanks, Davis. Really, the person that got me involved is Brent, Dr. Masel. He contacted me in the late 1990s, saying that a wealthy philanthropist on the island, Galveston Island, had a son who'd had a severe brain injury, and Mr. Moody did a lot of research into how to make his son better. And he hit upon the idea that there could be pituitary dysfunction after brain injury. And I looked in the literature, and there really were only a few case reports. And so I told Mr. Moody, I don't see anything here. And he said, well, if I give you the money, will you do a study? And I said, of course. And so we just basically looked at the first 70 patients, which came into a rehab facility that Brent oversaw for people who'd had traumatic brain injury. And when we did that, we found this 30% or so incidence of an abnormality in at least one of the 5 anterior pituitary hormones. And the most common of those was growth hormone. So we had a discussion amongst ourselves, and this was really driven by Brent, saying, there's not a lot to do for these folks, particularly these were very severe brain injury. A lot of them were younger, kids who'd finished high school, gone off to college, and been in a severe auto accident or something along those lines, flipped a four-wheeler, all of the things that young adults do. And there really was nothing for them. So there had been studies which had shown that abnormal growth hormone secretion or growth hormone deficiency in adults from the Scandinavian studies, when the adults were treated with it, they maybe had a little increase in strength, a little increase in energy, but nothing really significant. But because these patients were really so severely affected by their injury and really had no future of getting better, we decided to go ahead and treat these folks with growth hormone just to see if we could make a difference. And there are very strict definitions for growth hormone deficiency that have been on for a long time. And in order to find out growth hormone deficiency, you can't just measure a growth hormone level in the blood. It's secreted in bursts or pulses into the bloodstream, and these are dictated by GHRH, which is a growth hormone releasing hormone from the hypothalamus, and somatostatin, which is a gut hormone, and the two of those play into the balance of when a pulse of growth hormone happens. So you just can't measure a level and establish a growth hormone status. So there's stimulation tests. There are a lot of different stimulation tests that can be done. And the thought is to stimulate release from the pituitary to show that there is growth hormone being made by the pituitary. And you just look at the maximum level of growth hormone that's made by the pituitary to determine whether there's growth hormone in the pituitary or not. And so there are these cut points. And their insurance companies like to make them very strict because that way they don't have to pay for growth hormone. But we expanded those because we had this population of patients who really we didn't know if we could help them or not. And so usually, so they're one of the standard is whatever the test is, if your growth hormone goes higher than 10 nanograms per mil, then it's usually normal, and less than 10 is in this gray zone. And so we really took all comers who didn't have true growth hormone deficiency. And so we'll always use the term abnormal growth hormone secretion. That's how we were able to come up with people that we were going to treat in these studies. And as we began to treat these patients, particularly in the ones who were very severely affected, not so much the patients themselves because they had such severe injuries, but their carekeepers began telling us, hey, this is making a difference in these people, that they're more alert, they have more energy, they're more responsive, and it's really making a difference. So we found this very interesting, did a long-term study, 1-year study, looking to see if we could have any changes in neurocognition. And we couldn't study that many patients, so the results weren't overly dramatic, but there were trends, and we found trends in processing speed, executive function, and short-term memory. So that led us to begin to study. We wanted to look at physical function, but a lot of these folks were so impaired that they were in wheelchairs and other, or very limited in their physical activity. So we sort of moved to the next level, which was patients who'd had a severe brain injury, but were still very functional. So they classified as severe brain injury, but they were out in the workplace. They could drive cars, they could go to work, they could exercise. And we treated that group of patients with growth hormone and really found that a lot of them got significantly better. And this took about 10 years or so to go through all this. And then I began to notice, and it wasn't just me, but it was our team. Dr. Masel, Trey's on the call, Kate's on the call. As we studied these patients, they began to tell us the same thing over and over. And they had two basic components. One was fatigue. The fatigue was profound. They never had a good week. They never had a good day. And it really affected their lifestyle. They could go to work, and then at the end of the day, they'd be exhausted, and the family would complain because the husband or wife couldn't spend any time with the children because they were so exhausted. They had to take naps during the day. They couldn't, at work, they couldn't make it without taking a nap. They had a job which required concentration and focus. They couldn't stay on that very long at all. So that was the first symptom. The other symptom in the cognition was three very specific things: short-term memory loss. But the next two were fairly specific: processing speed, slowing of processing speed, and difficulty with word selection. They would know the word they want to say, but then they couldn't actually, put that word out there, and their spouse would fill it in for them and make them angry that they were doing that. And then loss of executive function. When I see these folks in clinic, if they were older, they'd have lists. They'd have to make lists in order to get themselves through the day. If they were younger, they did all this on their phone that told them where to go and when to do things. So short-term memory, slow processing speed, and loss of executive function. So remarkably, when we treated these patients with growth hormone, not all of them, about 85% of them showed improvement. It took about 3 months for the fatigue to improve. And it came on very slowly. When we start growth hormone, we don't just give them the dose, the maximum dose right away. I would start at a low dose for 2 months, watch the IGF-1, then go up, and then go up again. So it was a stair step how I gave the growth hormone. And but at around 3 months, they'd start noticing that they were doing things that they couldn't do before, that they were completing tasks and they weren't tired, that they were spending more time with their kids. And then at about 4 to 5 months, this foggy brain that they complained about began to clear, and they began to function better. If you take 10 as how they were after being perfect before any brain injury, and then a lot of them would come to see me with a 2 or a 3 on that scale. And we could get them to a 7, an 8, and sometimes even a 9. And they're over the moon because now they can go back to normal function and have their jobs and live their lives. They still have some deficits. They're not back to perfect, but they're a lot better than they were. And to make a long story short, we've been working with a great microbiologist, Dr. Rick Piles, and we found out that the cause of this is actually the gut microbiome. And that for reasons that we don't quite understand, when that injury occurs and this chronic process that Brent talked about gets set up, the bacteria in the gut go through a change, and this change is in their own energy metabolism, so that normally they're using carbohydrates and glucose for their energy metabolism. they switch to using amino acids, and in particular essential amino acids, for their energy metabolism. This then leads to lower neurotransmitter levels in the brain. Histidine is a good example of that, which we think causes the abnormal growth hormone secretion and causes the fatigue and altered cognition. Now, why growth hormone treatment fixes it, we still haven't figured that out. We don't know whether that has to do with growth hormone effects on the brain, whether it has to do with ghrelin and the ghrelin receptor, it's still unknown. But to close, we do know, we are certain that it's the gut microbiome that causes the problem, because Rick did an amazing experiment. We took the gut microbiome from patients with BIFAC, with this syndrome, and then we also took it from normals who don't have the syndrome, and we put it in germ-free mice. And the germ-free mice who got the microbes, bacteria from the folks who had the syndrome, the mice who'd never had a brain injury have actually developed the syndrome just like the patients. And so now we have this amazing animal model that we can use to begin to try and sort through this and study this, where the mice, we put them on a rotarod and they can't stay on as long as their compadres. They have abnormal growth hormone secretion and abnormal essential amino acid absorption. So we really are working now with this animal model to try and better understand what's going on. This doesn't happen to everyone who's had a brain injury. So we think there is an epigenetic or a genetic preponderance to this, but it is very dramatic in how you can help these folks with growth hormone. So I have people coming to see me from all over the country who have been to millions of doctors and had millions of tests, and then we're able to treat them and return them back to normal function. So it's a pretty great privilege that I've had. And now, just to finish this off, we've also seen that in patients who have long haulers from COVID, we noticed that many of them had the very same kind of symptoms as our traumatic brain injury patients. And we've just published a study where we've treated these types of patients with long haulers from COVID who have the neuropath symptoms similar to our brain injury patients. And all of them got better as well. So we think it's probably a bigger thing than just brain injury that causes this, and maybe a lot of different other causes that leads to these abnormalities in the gut microbiome. And I'll close with that.
Thank you very much. Fantastic, Dr. Urban. We'd love to have you back to just a lecture on this. So I'm going to invite you back next year to really dive in deeper if you're willing to come back. Hopefully,
sure, we're doing research together. You've got me.
I know I got you. Yeah. And by the way, we're trying to put together another study. If there's any multimillionaires on the call that want to fund a study on blast injured veterans, we're going to replicate that with the University of Texas Medical Branch Group. So stay on if you're able to grant fund. I'm gonna switch to Richard Seroussi and then end with Dr. Gianoli and then open it up with Q&A. Dr. Richard Seroussi is a PM&R physician. He works extensively with chronic pain. We started off this whole discussion of secondary factors with chronic pain. And I just want to bring Dr. Seroussi in to talk about his work. Dr. Seroussi, you've worked with brain injured patients for two decades or more. Is that right?
Yeah, well, pretty much since my training, which was back in the mid-90s, early 90s. But I think the field is moving so quickly. And I think the researchers here would say, Richard, they were moving quickly 30 years ago. But I think what's happened is that translationally, getting this sort of very exciting research out into clinical practice is a very slow process. And it's one that's still kind of a myriad of not quite clear what you need to do for your patient who has, oculomotor, vestibular, cognitive, sleep, post-traumatic headache, emotional disorders from a TBI, say a year ago. They've lost their job. Their family life is falling apart. Nothing got broken. And you have to figure as a clinician, what do I do? Do I send them to Dr. Mazeika? Do I send them to Dr. Gianoli? Do I give them melatonin? Do I try blue light therapy in the morning, which shows some promise? Do I just try a little medication here and there? It's actually very difficult to sort this out. Patients are not made of time. We tend to think as doctors that they are. They're not. You know, we've started hyperbaric oxygen in our clinic because it shows some promise, including for post-traumatic sleep disruption. And it turns out that if coming 90 minutes a day for 4 or 5 days a week for 30, 40 sessions, that's not a nothing. It's very hard for patients to show up for that. And they often got injured in a car crash. And now you're asking them to drive another hour a day for their treatment. So these are sort of the kind of where the rubber meets the road, what I have to confront. And I'm very excited by the speakers here and by the research presented. I still have to kind of work on my clinical pathways of, you know, do I treat primarily their pain? That's my natural thing to do. But there are obviously these larger issues. Do they have autonomic dysfunction? Do they have a vestibular problem that, as I've been calling it, they need a ticket to New Orleans to see Dr. Gianoli because they're not getting better? And so this is all just, you know, unfolding in my clinic, literally week by week, month by month. I think it's a very exciting time to treat patients with these problems, but it's also very complicated. There's almost like not enough time for the doctor, and there's not enough time for the patient to get this treatment. So you really have to learn to triage. Now, having said all that, in addition to treating pain, and especially with TBI, I try to treat headache and neck pain probably more aggressively than other areas. There are two things that I've learned in my clinic, and I often joke I never had to read a paper to learn this. One is if you have post-traumatic sleep disruption, and this is including for many of my whiplash patients, you're just not going to get better unless we can restore that. I mean, it's just sort of, I don't have to read an article on that. It's just, it's that simple. And I say to my patients, it's like filling a leaky bucket. I mean, we're never going to fill that bucket unless we can start to restore your sleep. And then the second thing is this post-traumatic stress issue, which it's almost adaptive in a good way. Early on, patients are, you know, they become very defensive drivers. They get this fight or flight thing. And they really think twice as they're going through an intersection, that they're going to slow down. Even if they think the other person sees them, they're going to try to make eye contact, etc. So they become very defensive drivers. But if this goes on for months and now they're flashing back all the time, and, you know, the grandmother who's in a crash, the kids are fine in the back seat, but she has nightmares about school buses falling off of cliffs and that sort of thing. You really have to treat that. And so those are probably the two major things that I see that are kind of the 400-pound gorillas in the room that if we ignore, one's a very common gorilla, the sleep, and the other's less common, but probably still under-recognized, is the, you know, is the post-traumatic stress sort of spectrum. They don't have to have a full PTSD spectrum, but they could have sort of something along that. And a few years ago, Dr. Frankie, who's at my clinic, his wife was a mental health counselor, and she learned some EMDR treatment and started to treat our patients. And I was just shocked at how many patients felt it was so helpful. So those are things, I guess those are the few things I want to add here. I think we still don't have great clinical pathways. I tried blue light therapy in the morning. The research suggests that works, but I guess the stuff on Amazon is not the real deal or something. Maybe Dr. Mazeika can, you know, send me an article on which form to get, or but, you know, these are the things that every day as a clinician, I have to really try to unpack and triage what I can and cannot do for patients. I think I'm going to stop there, Davis. I really want to hear from Dr. Gianoli as well.
Much. Yeah. Yeah, and I think no, thank you so much. I think to reemphasize how important PTSD is, you know, earlier I cited a paper that 22% of men, 28% of females develop PTSD after motor vehicle collisions. And so in the primary care setting, and I know some of you are going into primary care, the PTSD checklist, or the PCL-5, is a great questionnaire to have on hand. Also the IESR, the Impact of Events Scale Revised. And so all of my patients that come in receive those two scales. Research has shown that the PCL-5 correlates very highly with a structured clinical interview, the gold standard of which is the CAPS-5. The SCID is also used as well, the SCID-5. But you can, the Veterans Affairs and Department of Defense, endorses giving a provisional diagnosis of PTSD if the PCL5 score is greater than or equal to 33. And so I oftentimes will just give a provisional diagnosis. The military, the VA DoD has a free training, which is about 10 hours on PTSD. I encourage everybody who's a physician or practicing healthcare provider to go through that. You will learn a lot about that. Post-traumatic depression is highly comorbid with PTSD. Up 60 to 80% with PTSD will have depression as well. And so I'm in complete agreement with Richard, Dr. Seroussi, about the two gorillas in the room. I think Dr. Mazeika agreed that his gorilla in the room was chronic pain, meaning that's your leaking bucket. And so you're working back and forth between PM&R and sleep medicine to kind of get the big gorillas out of the room. And then we come in and back cleanup with endocrinology and vestibular medicine and neurology, autonomic dysfunction, and so on. So with that said, Dr. Gerard Gianoli is here today. For those of you that did not attend his lectures, they're now on our Nest YouTube channel. He got raving reviews, and we learned a ton on vestibulopathies. And so you taught me early on, I met you 2 or 3 years ago, Jerry, about the correlation between vestibular disorders and fatigue. So as they say, take it away.
So much to talk about.
Yes, please. And we got time. We're still in the hour. So go for it.
Kudos on this whole seminar. I just found this all fascinating. You know, all of these are specialties I don't deal with a whole lot from an academic standpoint, but they interact so much with what I do that it's just astounding. You know, the sleep medicine part of it, I swear to you, I probably sent a third of my patients for sleep studies, just because it's so prevalent among vestibular patients. And I'm not just talking about the post-traumatic ones. I'm talking about just vestibular disorders in general. And I was just curious as to how often do we see sleep disorders after head injury, because so often I'll order a sleep study and it'll get kicked out saying that's not related to his head injury. And I don't know what to say to that other than I know that there's a higher incidence. I just don't know what to tell them. So I was kind of curious what Dr. Mazeika would say about the post-traumatic sleep disorders. Is that?
I don't know. Davis, you can correct me. I'm kind of shooting from the hip. I just kind of my rule of thumb is that once the dust is settled, right, the vast majority of patients in the acute post-traumatic phase have sleep disturbance. They either sleep too much, they sleep all day long, or they don't sleep enough, or they have a combination of the two, where they'll go they hit turbulence, have sleep turbulence, and that can last for several months. But 6 months out, most of them are better. But I'd somewhere between 10 and 20% end up having a chronic residual sleep problem years out that just stabilizes and doesn't go away. Davis, do you think that that's fair assessment?
I think that's fair. That's not my area of epidemiology, but I hope some young researcher here will say, can we do a systematic review and figure that out? It may already be there in the published literature, but that sounds about right, Gandis. That sounds about right.
I must be seeing a select group of them because it seems like it's a whole lot more than 10 or 20% of the ones I see.
Just to chime in on that, yeah. It's a bias because you're seeing people who are enriched for sleep. You're seeing the worst. Right?
Well, let me propose something else, though. So let me propose that you're seeing patients with post-traumatic dizziness and disequilibrium, and there's a high correlation with sleep disorders. So, we talked a little bit about, let's see if we can go to a slide here that was presented. So there we go. Here's some publications on sleep and vestibular dysfunction. So that may in fact be the select population right there, is that you're literally seeing the patients that have the comorbid sleep picture, essentially.
I don't doubt it. And for the most part, I don't generally see patients until they're several years out from their head injury. And so I don't doubt it's a very select population. And just from a clinical standpoint, I don't have a clue what it is in the general public. That I thought the lectures were very comprehensive, but there's one disorder that you didn't include, or system, that I'm surprised. It's vision. And I was reminded of that with a patient this week. I saw that she had a head injury, car accident, like 3 years ago. And she gets sent to me, and I wound up doing surgery on her 6 weeks ago for a perilimb fistula. And I was seeing her 2 days ago for her 6-week post-op follow-up. And I never talk about vision or make any promises about vision, but she was so happy with the results from her surgery. And she's like, I'm thinking clearer, and my goodness, my vision is so much clearer now. And that's something that I hear from a lot of patients after we treat them. And there's a number of different reasons to get, visual axis mismatch, but one of the reasons is a vestibular problem. And we do see that improve when we treat them medically, but it's kind of gradually gets better. But a lot of times after surgery, it's like, boom, oh my goodness, then they'll see the results right away. And it's just that slight axis mismatch. I had another patient this week who's, oh gosh, she's probably been a patient of mine 20 years, who I was asking her about the visual stuff just out of curiosity. And she basically told me she didn't realize her vision was bad until she got fixed. And then it's like, oh, my vision's better now. But you can imagine if you've got, visual blurring, and what they get is just a little vertical axis mismatch to where the vision is just a little blurred. That's going to be another cognitive load on you that's going to add to the fatigue that we also see with the vestibular problems and the depression, et cetera. That I think that's another part of it. And I see that with the medical folks, when we start treating them medically, and then the neuro-optometrists tell me they have to keep changing their prism prescription. And it's because their axis mismatch is improving.
Yeah. Well, I will tell you, Dr. Gianoli, I considered putting vision in. And the reason I didn't is because I couldn't find, this is an EBM or evidence-based medicine program. So what I found was visual acuity deficits and visual field deficits greater than 30% are associated with systemic fatigue. The issue was what we're referring to now is more, you're referring to a vertical headophoria.
Right.
We've all learned, in fact, we have a lecture on convergence insufficiency that I actually did on the YouTube channel. But for those of you that aren't familiar, following concussion, you can get binocular vision deficits or ocular motor deficits. That's different than visual acuity. It's not assessed by a standard optometrist. You need to see what's called a neuro-optometrist. You'll see a long acronym, 5, FCOVD, which is a fellow of the College of Optometric Vision Development, and they will do extensive assessment for binocular vision disorders, the most common being something called convergence insufficiency, which is roughly, there was a study, 42% or greater in sports concussions. We're not sure in MVCs, but we suspect a similar mechanism. And what the ocular motor disorders do, whether it's the vertical headophoria that's influenced from the ears, from the vestibular system, or it's a binocular vision disorder independent of the vestibular, it can cause blurred vision when reading. It can make it very hard to track words. And so they get exhausted when they're reading, and when they stop, they feel better. And I do believe clinically, Jerry, that it causes systemic fatigue. I just didn't have enough. I can't prove it, but I will tell you, everybody that I see in my general brain injury medicine practice, because I do that, but I focus on neuroendocrinology, we're looking at ocular motor function. We're testing near point of convergence with the Royal Air Force rule. And it's really important to test that and to try to fatigue the visual system. So oftentimes when you measure a convergence insufficiency, you're doing it once or twice. The ophthalmological guidelines actually recommend up to 10 times. And so if you measure that 10 times, what you'll find is you get a receding near point of convergence, and you can see how fast the visual system is fatiguing. I agree with you 100%. I just couldn't sneak it in because I didn't have the citation. So that's my 2 cents on it. So before we go, increased intracranial pressure. You've talked about this. You use things like acetazolamide to lower that pressure. That improves vestibular symptoms. We had a little crosstalk with Dr. Mazeika about potential ICP increases with the glymphatic pathways. You spoke about this. Can you kind of reiterate a little bit about that role in vestibular disorders?
Sure. So, one of the things that we've identified over the years that there's a number of folks with vestibular disorders, and I'm not just including the post-traumatic ones, but just a number of them where increased intracranial pressure is kind of the basis for why they're having their vestibular problem. And, whenever I mention this, everybody wants to jump to start thinking about idiopathic intracranial hypertension, which is you got the pseudotumor triad of headaches, papilledema and raised intracranial pressure on LP. This group almost never has papilledema. And I think the issue is they're not necessarily at really, really high levels, but it's high enough to where the pressure going to the inner ear can cause disturbances there. And typically in these folks, lowering the pressure makes their symptoms significantly better. And of course, from a medical standpoint, acetazolamide is the #1 drug for that. But even more dramatically is to look at some of these folks after a lumbar puncture. If I have any question about it, I'll have them do a lumbar puncture and drain them down to a low normal pressure level, and they'll notice immediate improvement for the most part with these folks. Now, treating them long-term is another story too. Some of these folks are on long-term acetazolamide. Some of them I wind up doing surgery to kind of blunt the connection to the inner ear, if you would. And some of them I refer to neurosurgery for shunts.
Well, we've got a few questions.
Well, I'm just looking at a comment from Dr. Mazeika about pretty high levels of obstructive sleep apnea after TBI. And I guess I would echo that. It seems like a lot of my chronic TBI patients probably have significant sleep disorders. I don't know that I send them enough for sleep studies, but it seems like sleep disruption is just a very central part of treating chronic pain, TBI, and even spinal injuries.
And to add in, you can run, there's a questionnaire called the Stop Bang questionnaire that if you're in primary care, you can use. And it helps kind of give you a pretest probability of obstructive sleep apnea. And I just put that in the chat. So if you're learning primary care medicine, you want to be running the Stop Bang. The other thing that you want to think about in traumatic brain injury is always asking them what their weight was at the time of injury and what their weight is now. And you will oftentimes, I would say the vast majority of my TBI patients gain weight, or there's an adverse change in body composition towards greater fat deposition, central adiposity. There are endocrine conditions, especially growth hormone deficiency and testosterone deficiency, that can contribute to that. But it's oftentimes, weight gain is associated with chronic pain. Weight gain is independently associated with insomnia, and so forth. So you're going to find that change in weight is an increased risk factor for obstructive sleep apnea as well. If you have any other questions and you're attending today, I think all of you have my email. Please email me. I can be in touch with any of the experts that were on the panel today. Trying to build a community here, and we're going to do more of this next year. So give us some feedback on how you liked the panel. This is the first time we've done this at the end of a student lecture. And if you like the panel format, as long as the experts have the time, we'll continue to have panels in the year to come. And wishing all of you a very happy holiday season and a terrific weekend. Thanks again, everybody.